Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss the recall questions of FMG June 2022 Pharmacology chapter. So without wasting time, starting with the first question, what does LD50 signifies? So in our video lectures, we discussed there are two terms called as LD50 and ED50. The other name of these is LD50 is median lethal dose, whereas ED50 is median effective dose. So what is meant by median is how many number of animals receive this dose or humans receive this dose out of that 50%. So that 50% is called a median. So LD50 means it is that dose at which 50% of the recipients, they may be animals, usually animals, 50% of the recipient dies. Okay, similarly ED50 means median effective dose, that means that dose at which 50% of the recipients, they get the desired response. Okay, so simple question, what does LD50 signifies? It is the dose at which 50% of the animals die. Remember, it is not 50 animals or it is not the desired response, it is 50% of the animals will die. Okay, second thing, there is a term called as therapeutic index. This is given by a formula LD50 by ED50. So therapeutic index is LD50 by ED50. You can remember that from the mnemonic tile, therapeutic index is equal to LD50 by ED50. So therapeutic index tells the safety of a drug, or we can say margin of safety of a drug, means the drug which has higher therapeutic index is more safer, like penicillins, they are very safe. On the other hand, drug with lower therapeutic index are relatively unsafe drugs like lithium or anti-epileptic drugs. We want to maintain them between a narrow concentration range. Okay, so that is important. So LD50 is the dose at which 50% of the animals die. Okay, moving to second question. All of the following are side effects of ritodrin except. So what is ritodrin? Yes, ritodrin is beta 2 agonist. So what the examiner has done this time, this is a repeat question slightly changed. What is changed is, previously the examiner used to ask the question on side effects of salbutamol. Salbutamol is also beta 2 agonist. So now they have changed the name from salbutamol to ritodrin. So they are asking ritodrin, what is not a side effect? The answer still remains same. For salbutamol, all were the side effects except hypoglycemia. Beta 2 agonists, they increase blood sugar, do not decrease. So hypoglycemia cannot be the side effects. Okay. So ritodrin is a beta 2 agonist. It can cause tachycardia. Any beta 2 agonist, if given in overdose, can stimulate beta 1, that can lead to tachycardia. Hypotension, yes, beta 2 is a vasodilator, that can lead to hypertension, and the specific side effect of ritodrin is pulmonary edema. It can cause pulmonary edema. So the answer is hypoglycemia. It does not cause hypoglycemia. Okay, moving to next question. A patient with history of snake bite presented in emergency with symptoms of fatigue and irritability. 10 vials of antivenom were administered IV. So the person has already received 10 vials of antivenom, but the patient is still having difficulty in swallowing, ptosis and respiratory distress. So that means what is the problem? Yes, problem is muscular. So neuromuscular problem. So do you remember which snake is neurotoxic? Yes, we discussed in our lecture, it is cobra. So it is a cobra bite. So cobra bite, we need to give antivenom, which has been given. So if antivenom still is not able to improve the muscle symptoms, what we will do? Yes, we will give neostigmine. Remember neostigmine, it will inhibit acetylcholine esterase. That will increase acetylcholine. And when acetylcholine increases, it will stimulate the NM receptor, so muscles will start working. But problem is, when acetylcholine increases, it will stimulate muscarinic receptors also. So that will lead to side effects. So to stop those side effects, we are giving a muscarinic blocker, which is atropine. So atropine plus neostigmine will be given to this person. Okay. Moving to next question. It's an easy one. A known patient of bronchial asthma was started on treatment with anti-glaucoma drug. During the course of treatment, asthma worsened. So simple question, which anti-glaucoma drug can cause worsening of asthma? And we all know that is beta blockers. So the drugs ending with LOL, beta blocker, commonly used beta blocker in asthma is timolol. So timolol can worsen asthma. So you can remember the main problem with beta blockers. We remember them as A, B, C, D. A for asthma, they can cause worsening of asthma. B for block, they can lead to AV block. C for CHF, they can worsen acute CHF. And D for diabetes, they are avoided in diabetic patients. They cause hypoglycemia unawareness. Okay, so asthma answer is timolol. Okay, moving to next question. Which of the following is fastest urate lowering therapy in tumor lysis syndrome to prevent renal damage? So read the question carefully. What happens in tumor lysis syndrome? As the name says, tumor lysis. So that means when a tumor breaks, large amount of intracellular substances will be released in the blood. So one of them is uric acid. So that lead to sudden increase in uric acid level. So we want to decrease this uric acid immediately. The question is fastest drug. We want to decrease it immediately. Remember, if we want to remove this uric acid from the kidney, it will take time. Plus there is chances of obstruction of the tubules with so much uric acid. So that is not a good choice. If we give a drug which inhibit the formation of uric acid like allopurinol or febuxostat, they also will inhibit the formation of new uric acid, but the uric acid which is already present will be there. So the fastest acting drug is that which will help in metabolism of this uric acid, and this is done by an enzyme called as uricase, which will convert the uric acid into allantoin. So this will be the fastest acting drug, and the recombinant uricase enzyme is RAS buricase. RAS buricase, as the name tells, it is a uricase enzyme obtained from birds made by recombinant DNA technology. So this is the fastest acting urate lowering agent, particularly used in tumor lysis syndrome. Okay, so the answer is RAS buricase. Okay, moving to next question. A patient presented with unstable angina and was started on aspirin, 325 milligram of aspirin. What is the correct about mechanism of action of this drug at this dose? Remember, aspirin act at different doses for different indications. When we give aspirin less than 325 milligram, it is used as antiplatelet drug. So we all know it is antiplatelet. Aspirin act by inhibiting cyclooxygenase enzyme. It inhibits both COX-1 and COX-2, mainly COX-1. But important thing is, in endothelium we have mainly COX-2, whereas in platelets we have mainly COX-1. So when we inhibit COX-1, it will decrease the thromboxane A2 as well as prostaglandin by inhibiting COX-2 in the endothelium. But finally, the endothelium has nucleus, so they will regenerate new COX enzyme. So only final effect is decrease in thromboxane A2, and you can remember thromboxane A2 cause A for aggregation. So when there is less thromboxane A2, there will be less aggregation. So the main mechanism is to inhibit aggregation of platelets. If you see, it acts by inhibiting COX-1 in both endothelium and platelet is slightly wrong. It inhibits COX-1 in platelets and COX-2 in endothelium. Okay. So even if they do not give endothelium, they say inhibit COX-1 in platelets, still I will prefer the answer as aggregation of platelets, because finally even after inhibiting COX-1, the final effect is due to inhibition of aggregation of platelets. Is it clear? So the answer is it inhibits platelet aggregation. Moving to next question, question 7. A non-hypertensive patient came to emergency department with complaints of palpitations and shortness of breath. Her BP was 220 by 140, so hypertensive emergency. Among the options given below, which drug should not be used in treatment of this patient? So simple question is, which drug is not given in hypertensive emergencies? So we'll look at the options one by one. Sodium nitroprusside, yes, it is a fast acting antihypertensive drug used commonly in hypertensive emergencies. IV esmolol, yes, esmolol is a short acting beta blocker and it very quickly decreases blood pressure. In particular, it is given with other drugs like nicardipine, which cause vasodilation, which can result in sudden tachycardia. So esmolol is very commonly combined with nicardipine also, right? So it can be used. Nicardipine is usually the drug of choice for hypertensive emergencies, and mannitol is the answer here. Mannitol is not used for hypertensive emergencies. It is used for cerebral edema. This person do not have edema. This person is having hypertension, so we will not use mannitol in this person. Okay, moving to next question. A patient with chronic stable angina presents with pedal edema, breathlessness, and other symptoms of heart failure. So patient is having heart failure. Which of the following drugs can increase longevity in this patient? So be very careful. We discussed in our lectures that only 4 drugs can decrease mortality or increase longevity in a patient with heart failure. What are those 4 drugs? If you remember, we started with kidney, which has beta 1 receptors in the JG cells that will release renin. Renin convert angiotensinogen to angiotensin first, which is converted to angiotensin second with the help of ACE. Angiotensin second will stimulate the AT1 receptors. That will result in increase in aldosterone. And it is this aldosterone which causes left ventricular hypertrophy, which can lead to death of the person. So if we stop this pathway, we can decrease mortality. And the drugs which do so are number 1, beta blockers. That means the drugs ending with LOL, like carvedilol, bisoprolol, and metoprolol. Then we have drugs which inhibit ACE. That means the drugs ending with pril, like lisinopril, enalapril, captopril. Then we have drugs which are AT1 receptor blockers. That means the drugs ending with the sartan, like losartan, valsartan, telmisartan. And lastly, we have drug which is aldosterone antagonist. The drug is spironolactone. So these are the drugs which will decrease mortality. Other drugs are for symptomatic relief. They cannot decrease mortality. So answer is lisinopril here. If you see, torsemide is a loop diuretic used for symptomatic relief. Digoxin is a inotropic drug. It is used in acute CHF, not in chronic, but it cannot decrease mortality. And nifedipine, it is a drug which causes increase in heart rate. So it is rather avoided in patient with heart failure because it can depress the heart and rather increase the workload by increasing heart rate. Okay, so the answer here is lisinopril. Moving to next question. A female washing clothes in the cold water exhibited color changes of her hand from pallor to red. Which of the following? So first of all, what is the diagnosis? Yes, this phenomenon is known as Raynaud's phenomenon. Basically, what happens normally whenever we are exposed to cold, our body tries to conserve the heat, so it causes vasoconstriction. But some people, they are very sensitive, in which a little bit cold can cause severe vasoconstriction, which can lead to ischemia in the periphery. So this woman, it is suffering from Raynaud's phenomenon, means when she put her hand in the cold water, it can get suddenly pale. But after some time, when the vasoconstriction dilation occurs, so again it become red. So pallor to red, it is a Raynaud's phenomenon. So this is known as peripheral vascular disease. And we know the drug of choice for peripheral vascular disease should be a vasodilator, and that vasodilators which are preferred are calcium channel blockers. So calcium channel blockers are drug of choice for peripheral vascular disease. Easy question. Okay, moving to next question. This question we discussed several times, direct stat question. Drug of choice for hyperthyroidism in first trimester of pregnancy, it is propyl thiouracil. So propyl thiouracil, we write it as PTU, and in Hindi you can remember very easy. It is saying पहले ट्राइमेस्टर में यूज करना है, तो पहले ट्राइमेस्टर में यूज करना है. सो PTU, that is drug of choice for hyperthyroidism in first trimester of pregnancy. Okay. Moving to next question. To minimize the risk of HPA axis suppression, what is the correct method of administration of prednisolone? So this is very important concept. If you listen to our detailed lectures on the corticosteroids, so we discussed HPA axis suppression is the most dangerous adverse effect of steroids, because normally when we give steroid, they exert feedback inhibition. Whenever steroid become less in the body, pituitary can again release ACTH, so again steroids can be produced by the body. So this is a normal phenomenon of feedback inhibition. Whenever steroids are enough, they will themselves inhibit their more production. But problem is, if we give exogenous steroid, they can also inhibit pituitary. So when they inhibit pituitary, the adrenal gland will stop working because ACTH is not come. So if we keep on giving steroid from outside for more than 2 weeks continuously, what will happen is adrenal gland do not produce steroid continuously for 2 weeks. And if such a thing happens that now adrenal gland forget that it has to do something, so it forgets to produce steroids. So that means even if we stop giving steroid from outside, still adrenal gland do not produce anything. So when it do not produce anything, that will lead to sudden deficiency of steroids in the body, so the person can die. So this is the danger of HP axis suppression. So we need to give steroids in such a manner that HP axis suppression risk is minimum. So what are the options? I told you earlier, do not give steroids. That is the best option. If we can manage the patient without steroids, excellent. HP axis suppression, no chance. Suppose giving steroid is necessary, then give them for minimum possible period, preferably less than 2 weeks. If we give them for 1 week, maybe 10 days, 5 days, then HP axis suppression is unlikely. Suppose giving them more than 2 weeks is necessary, suppose we need to give them for 6 months, what we will do? We'll try to give them on alternate day. So that in 1 day we give from outside, 1 day body produces, and another day we give from outside, another day body produces. So if the body keep on producing in between, then HP axis suppression will not occur. And if a steroid is very long acting, like betamethasone, dexamethasone, they are working for 36, 48 hours. So in that case, even alternate day therapy will cause HP axis suppression. So if there is on alternate day therapy, we should give short acting steroid, not long acting. Okay, suppose the disease is severe, we cannot afford to give on alternate day, we have to give daily. Then the only thing which we can do is, because the HP axis suppression will occur, so then what we will do is we will gradually taper the steroids. So these are the method of preventing the HPA axis suppression in sequence. So if you see, give at night just before bedtime, no, if in the morning steroids are produced maximum, so that is the physiological thing, but even with physiological, HPA suppression can occur. So that is not the method. Divide in 3 doses is not done, because if they are continuously present, HP axis suppression can occur. Give on alternate day is the answer. Replace with betamethasone. No, betamethasone is a long acting, it has even higher chances of causing HP axis suppression. The answer here will be give on alternate day. Okay, moving to next question. Which enzyme is involved in peripheral conversion of T4 to T3? So we discussed in our videos, T4 is 3, 5, 3 prime, 5 prime, tetrahydrothioronine. That is the name of T4, full name of T4. So when we convert it into T3, 403 means how many iodines are there? So T3, the name is 353 prime triiodothyronine. So what we have done is we have removed iodine from which place? 5 prime position. So the enzyme is simple, it is 5 prime deiodinase, which is removing the iodine from 5 prime position. So peripheral conversion from T4 to T3 is done by 5 prime deiodinase. Okay, moving to next question. This is a repeat question, guys, do not get confused, it is a repeat question. Which drug used in arthritis act by both opioid and non-opioid mechanisms? First you see the options, you will answer it without looking at anything else. If you see paracetamol, ketorolac, diclofenac, all of them are non-steroidal anti-inflammatory drugs. They do not act on opioid receptors. So there is only one drug which acts on opioid receptor, it is tramadol, that is the answer. But if you see, most of the opioids like morphine, heroin, pethidine, they act on mu, kappa and delta receptors. They stimulate these receptors which are opioid receptors, and they cause powerful analgesia. But tramadol has a dual mechanism. Tramadol, it not only stimulates the opioid receptors and cause analgesia like all opioids. In addition, it also cause increase in serotonin and noradrenaline in the spinal cord. Remember, serotonin and noradrenaline act like analgesic substances, so they contribute to analgesic mechanism. So tramadol has two mechanisms: opioid mediated mechanism and non-opioid mechanism. Okay, so other three drugs are non-steroidal anti-inflammatory drugs. They do not act on opioid receptors. So question is very easy. The answer is tramadol. Okay, moving to next question. A patient with history of drug abuse presented to emergency in comatose state. Vitals recorded were respiratory rate is 8. So respiratory depression. BP 90/60, depressed BP, pulse 52, depressed heart. So which and plus pinpoint pupil. So it is the characteristic toxicity of opioids. So if you remember opioids, the main points are remembered as sacrum. S for sedation. So opioid cause sedation. In overdose, person can go into coma. They not only depress the brain, but also along with brain can depress the cardiovascular system, which can contribute to hypotension and bradycardia. Okay. Then A for analgesia. Opioid mainly used as analgesic. C for constipation, that is the important side effect. R for respiratory depression. So that is seen in this person, respiratory rate of 8. Respiratory depression. Euphoria, they are addictive drugs, cause euphoria. And M for meiosis means pinpoint pupil, they can cause pinpoint pupil. So these are the symptoms of overdose of opioids. So which is the opioid here? The answer is morphine. So these are seen in morphine poisoning. Okay, moving to next question. A female visits the OPD to get rid of tobacco addiction, which is will provide. So simple question, which of the following is used in tobacco de-addiction, or we can say anti-smoking drugs? So three main anti-smoking drugs you must know of. These are nicotine replacement therapies. That is the most commonly used in India. Nicotine replacement, we have nicotine chewing gums, nicotine patches. There are many nicotine products. Basically, instead of nicotine taking from the smoke, we give the person to take nicotine as tablet or as patches, so that person do not get the withdrawal symptoms and can slowly taper it off. Second important drug is bupropion. Bupropion. And third important drug is varenicline. So these are the three important drugs you should know which are used as anti-smoking drug. So among these drugs, the option contains varenicline. So that is the answer. Naloxone is used in opioid poisoning. Disulfiram is for alcohol, and flumazenil is used for benzodiazepine poisoning. So answer in this case is varenicline. Okay. Moving to next question. A patient was started on lamotrigine 50 mg daily for treatment of epilepsy. Gradually, the dose of drug is increased every 1 to 2 weeks to reach the final dose of 200 mg per day. This step-up titration of lamotrigine is done in order to prevent or minimize the development. Why we do not give lamotrigine full dose right in the beginning? The main reason with lamotrigine is it can cause Stevens-Johnson syndrome or toxic epidermal necrolysis. These are very severe skin reactions. There is desquamation of skin. The person can die because of infections. These are very dangerous side effects. So what we do, we will gradually desensitize the person by slowly increasing the dose, so that these side effects do not occur, and even if they occur, we can come to know early and prevent the mortality. So that is the main reason. That means skin rash. So we want to prevent the skin rash. That's why we do up titration in case of lamotrigine. Okay, moving to next question. A 25-year-old female present with mania. History revealed that her father is taking medications for bipolar disorder. So which drug? So simple question, what is drug of choice for mania or bipolar disorder? So that is very easy. You all know the drug of choice is lithium. Lithium is drug of choice for mania and bipolar disorder. But if the question is asked in pregnancy, drug of choice for mania or bipolar disorder in pregnancy, then the answer will be antipsychotic drugs. Antipsychotic drugs are drug of choice for bipolar disorder in pregnancy, like olanzapine, risperidone. They are preferred in pregnancy. Okay. Moving to next question. Another repeat. Last year also it was asked. A patient was administered a local anesthetic and developed tachycardia, palpitation, hypertension, arrhythmias, cardiovascular collapse. So it is local anesthetic overdose. So drugs which end with cane, like bupivacaine, lignocaine, prilocaine, their overdose can cause these side effects, and the drug of choice for overdose of this local anesthetics is 20% intralipid. So that was the direct question asked last time also, the same question asked now in the form of history. So it is 20% intralipid drug of choice for local anesthetic toxicity. Okay, next question. A patient presented to hospital with chest pain. ECG confirms non-STEMI. Which drug is useful that act by inhibiting platelet aggregation? So the simple question is, which of the following is anti-platelet drug? And if you remember our lecture, we have three important substances which we can target for inhibiting the platelet aggregation. These are thromboxane A2, adenosine diphosphate, and glycoprotein 2b/3a. The drug which inhibit thromboxane A2 is A for aspirin. Aspirin inhibit thromboxane A2. But the drugs which inhibit ADP are ticlopidin and clopidogrel. And the drug which inhibit 2b/3a is abciximab. So you can remember these mechanisms from the name themselves. A for aspirin. So thromboxane A2 is inhibited by aspirin. ADP is inhibited by the drug which contain D in the name, that means ticlopidin and clopidogrel. And 2b/3a contains B and A in the name. So the drug which contain B and A together, it is inhibiting 2b/3a. So aspirin, ticlopidin, clopidogrel, abciximab, these are the antiplatelet drugs. So if you see the options, clopidogrel is the answer here. It is antiplatelet drug. Clopidogrel, it is antiplatelet drug. Whereas other option, streptokinase is a thrombolytic drug. It will break the thrombus, not antiplatelet drug. Low molecular weight heparin and warfarin, they are anticoagulants. They are not antiplatelet. Okay. So question asked is which is antiplatelet? The answer is clopidogrel. Okay. Moving to next question. Which anticoagulant is contraindicated in first trimester of pregnancy? The easiest one. Very, very frequently asked question. The answer is warfarin. We know warfarin can cause fetal warfarin syndrome if we give during pregnancy. It is a highly teratogenic drug. If given in pregnancy, it can cause fetal malformation, so avoided in pregnancy. So other drugs are safe. Answer is warfarin. Heparins, unfractionated or low molecular weight. Enoxaparin is also a low molecular weight heparin. So these are safe in pregnancy. Warfarin is contraindicated. Okay. Moving to next question. A 25-year-old male has frequent visit to rural areas and need to eat outside food. So when the person is frequently eating outside food, what is the risk? Yes, there is risk of infections, food poisoning. So during one such visit, he developed loose stools. So symptoms of poisoning, food poisoning, diarrhea. So which drug should be used? So important thing is this is likely to be infectious. So we need to give drugs to control the infection. So two type of drugs. Most commonly it is amoebic infection. So we can give metronidazole group of drugs, metronidazole, tinidazole like drugs. And if it is due to bacteria, then we need to give antibiotics like fluoroquinolones. Okay. So we need to give some anti-amoebic or antibiotics. So the answer here is metronidazole, which is an anti-amoebic drug. Diphenoxylide and loperamide, they are anti-motility drugs. They are indicated only for non-infectious diarrhea. They are only for non-infective diarrhea. They are contraindicated if it is infection. And octreotide is used for conditions like carcinoid syndrome, VIPoma. They are not used for routine cases, only for severe cases like carcinoid syndrome and VIPoma. In particular reason, octreotide is not effective orally. We need to give subcutaneous injection. Okay. Next question is direct rectification question. What is drug of choice for Legionnaire's disease? The answer is azithromycin. We know azithromycin is a macrolide. And if you remember, we discussed that drug of choice, macrolides are drug of choice for 4 conditions remembered as CLAP. So these are drug of choice for chancroid, Legionella, that means Legionnaire's disease, atypical pneumonia, and pertussis. Pertussis means whooping cough. So chancroid, Legionella, atypical pneumonia, pertussis, drug of choice are macrolides like azithromycin. Okay. Next question is again easy question. A patient developed COVID-19 pneumonia and was treated. Pneumonia, COVID-19 pneumonia, the only life-saving drug is, yes, steroids. So few months later, the patient presented with nasal congestion and swelling of face. There were black lesions of the nose bridge and a diagnosis of mucormycosis. So it was in news for a long time. After the COVID treatment, says steroids can suppress the immunity that can lead to mucormycosis. What is the drug of choice? And we all know mucormycosis is a very serious life-threatening fungal infection, and drug of choice for almost all serious fungal infections is liposomal amphotericin B. So amphotericin B is a drug of choice. Dexamethasone may have caused this condition by suppressing the immunity. Okay. Moving to next question. A patient with head and neck cancer is planned to receive radiotherapy. So which drug can result in increased histotoxicity. So basically, which drug is radiosensitized? They are asking which are the radiosensitizing drugs. So these are the drugs which will sensitize the body cells against radiation. So that means the same dose of radiation can cause more damage. Sometimes they are added to the radiotherapy to decrease the radiotherapy amount. So the amount of radiation we can reduce because the drug will sensitize the body to same amount of radiation. So the important radiosensitizers, these include all trans-retinoic acid, simply vitamin A or retinoic acid. Then we have bleomycin, we have cisplatin, doxorubicin, dactinomycin also, epirubicin. Then we have 5-fluorouracil and gemcitabine. So among the anti-cancer drugs, these are the important drugs which are radiosensitizers. But among drugs which are not anti-cancer, the most important drug you need to remember is metronidazole. Metronidazole is a very strong radiosensitizer. Okay. So anti-cancer drugs you can remember from the mnemonic A, B, C up to G. So A for atra, all trans-retinoic acid, B for bleomycin, C for cisplatin, D for doxorubicin, E for epirubicin, F for fluorouracil, and G for gemcitabine. So A, B, C, D, E, F, G. These are radiosensitizer. So if you see the options, it is cisplatin in this. So answer is cisplatin. Okay. Moving to the last question, although it is a question of forensic medicine, but as we have discussed drugs, so we can discuss this also. A patient presented with abdominal pain, constipation, lethargy, altered mental status. On examination, there were blue lines of the gum. So all are symptoms pointing toward lead poisoning, and it shows that serum lead levels were more than 80. So serum lead level is high, so it is confirmed to be lead poisoning. So what is the appropriate management? So the patient is having altered sensorium, patient is having high lead levels, very high lead levels. So we need to give a strong chelating agent, particularly IV therapy. So intravenously, or we can say parenteral therapy, we give combination of EDTA, that means calcium disodium EDTA with dimercaprol. This combination is given parenterally. It is drug of choice or treatment of choice for acute lead poisoning. But if the poisoning is not that severe, the level is slightly lesser, and there are no CNS symptoms, mild symptoms are there, then we would have preferred oral therapy, and the oral therapy is DMSA. That is oral therapy. Other name of DMSA is Succimer. So that is the preferred for chronic lead poisoning or mild lead poisoning. But for severe cases, we will give combination of EDTA with dimercaprol. Okay. So these are the important questions which are asked in FMG 2022. So I hope you have made most of them correct. If any queries, you can ask. Thank you very much.